To continue, what should be done for patients who are not improving after 72 hours of empiric antibiotic therapy? So we have to do a complete reappraisal first, rather than to simply select alternative antibiotics. So we must do a review of the clinical history, do a repeat or redo our physical examination, and review the results of available investigations. Then we should consider reasons for lack of response to the treatment of CAP. So the clinical practice guidelines enumerated the different reasons on why a patient may not be responsive of the empiric antibiotics that you started on admission. So first off is that it may be the correct organism, but the inappropriate antibiotic choice or dose. There could be a resistance of the organism to the selected antibiotic, and these two we will only be able to know once the cultures are out. Or it could be it's because of a wrong dose. Maybe the dose is too low in comparison to the patient's weight. Patient may be unresponsive because the antibiotics are not administered. Which is the reason why once you go into practice, it is very important to look at the medication sheets. Make sure that the medications are given. Make sure that the nurses were able to countersign all antibiotics that were given. Because remember, no signature from the nurses means that the medication was never given or was not given at all. So next reason would be, it may be because it's a correct organism and a correct antibiotic, but the infection is loculated, like in cases of abscesses or empyema. Or it could be secondary to an obstruction wherein there is a pulmonary mass and the pulmonary mass is surrounded by infection, or because of the pulmonary mass, it's blocking the airways, causing pneumonia or infection in the distal part of the airways, distal to the pulmonary mass. Or it could be secondary to incorrect identification of the causative agent by the laboratory. There is no identification of causative organism and empiric therapy directed toward wrong organism. Or it could be secondary to a non-infectious cause like malignancy. Remember, malignancy can present with fever. Or it could be secondary to a drug-induced fever. Or it could be secondary to the presence of an unrecognized or concurrent infection, which is the reason why, in the long run, one of the workup for patients with fever of unknown origin, infectious disease specialists would request for a CT scan of the abdomen or the chests. Okay, base na ay abscess nasa retroperitoneal area. Diba? Okay. So when can a hospitalized patient with CAP be discharged? This is the most exciting part of the patients. They are so excited on discharge, especially if the patient has been there in the hospital for like 2 weeks. It's the most awaited part of the patients, as well as maybe the doctors, because the doctors would feel very fulfilled if the patient was able to discharge after weeks or months in the ICU. So during the 24 hours before discharge, the patient should have the following characteristics. Patient should be afebrile. Patient should have pulse rate and respiratory rate within normal limits. The BP is stable. Patient has good saturations at room temperature, and the patient has a functioning gastrointestinal tract, meaning the patient is able to eat and the patient is able to defecate. What other information should be explained and discussed with the patient on discharge? Explain that the symptoms are expected to steadily improve, although the rate of the improvement will vary with the severity of pneumonia. This is very important because patients may come back on follow-up and say, Dok, wala pagi ko nayuan, Dok. Nabalagi akong ubo. Dok, medyo gahangos pagyapon ko usahay. Now, as mentioned here, it's a case-to-case basis. If your patient was intubated, patient was in the ICU for a very long time, then the recovery would also be for a very long time. So the shorter the duration, the less severe the infection, the faster the recovery will be. And the longer the patient stay in the hospital, the more severe the pneumonia is or was, then the recovery is sluggish and it takes months. Remember, at 1 week after patient was admitted, the fever should have resolved. If not, you have to investigate as mentioned earlier. 4 weeks after onset of symptoms, the chest pain and the sputum production should have substantially reduced. At 6 weeks after onset of symptoms, then some patients may say that the cough and the breathlessness have substantially reduced. Some would say that it's only up to 6 months wherein the patient feels to be fully recovered. Again, it's a case-to-case basis. So if my patient would come in, I would say to them outright that pneumonia takes time to heal, depending on how ill you were, how severe the infection was, the nature or the type of pathogen that the patient had, as well as the patient comorbidities. Like for example, if a patient has asthma, they would have longer recovery time than patients who have had pneumonia but were without asthma. Okay. So how can pneumonia be prevented? So this is how you will be able to more or less prevent CAP: by influenza vaccination, through pneumococcal vaccination, and smoking cessation. So if you're actually a smoker, I know some of you are smokers, maybe one or two, and I may not be surprised if there are 10 of you who would be smokers. I would really advise you to stop, because even if you would stop, remember that there would still be residual effects on your lungs, but it would be more permanent and it would be more severe if you won't be able to stop as early as now. Okay. Now, with regards to flu vaccination and pneumococcal vaccination, it does not connote 100% prevention from pneumonia. Okay? Dili gid siya mo hatag 100% assurance nga dili na gyud ka magka-pneumonia sa tibuok nimong kinabuhi. It may decrease your risk for severe types of pneumonia. It may minimize the incidence of pneumonia because you've been given flu and pneumonia vaccines. Now, the question now is flu vaccine for everyone? Now, these are the indications for influenza vaccination based on CDC. So all persons who are aged more than 50 years old, patients with chronic illnesses, with immunosuppressive conditions, patients who are pregnant in their second and third trimester, residents of the nursing home, healthcare personnel like doctors, nurses, midwives. Flu vaccination may also be considered in household contacts and caregivers of children aged less than 5 years old and adults aged more than 50 years old. or household contacts and caregivers of persons with medical conditions that would put them in high risk for severe complications of influenza. So for us doctors, it is very important that we do have our annual influenza vaccination. Now, there are two flu vaccines available in the market. You have the trivalent and the tetravalent. The trivalent means that it has three strains of flu. The flu virus, and the tetravalent have four. So I would really prefer that you would have the tetravalent flu vaccines. Okay. It is yearly because the manufacturers would make them in January of that year, and then it is distributed sometime in March and April worldwide. And the vials or the preparations would expire on December of the same year. The rationale why there is a yearly vaccination, it's primarily because the creation of the manufacturer of the vaccines would depend on the most prevalent flu strains that was seen in the previous year. And then so they develop their flu vaccine accordingly. Is pneumococcal vaccination recommended for everyone? Now, these are the indications. Patient should give pneumococcal vaccination for persons aged more than 60, persons with chronic illness like COPD, bronchiectasis, diabetes, chronic liver disease, renal failure, kidney failure, patients who are immunocompromised, like with patients with HIV/AIDS, cancer, or residents of nursing homes and other long-term care facilities, as well as those patients who are smokers, as well as those who are asthmatic. So there are two types of pneumococcal vaccines. You have the PPSV23 and the PCV13. The PCV13 is considered as a lifetime because it is only given once in a lifetime. So it is highly recommended in patients more than 60 years of age. But for patients who are in the front lines like you and I, then we may consider having the PCV13 earlier. Okay, especially if you have comorbid conditions that would increase or lower down your immune system. The second type of your pneumococcal vaccine is your PPSV23, which is popularly being sold as Pneumovax 23. Okay, so you may opt to have this as younger individuals with no comorbids but who are considered as frontliners. Then you may consider the PPSV23 rather than the PCV13. The PPSV23 is given for 2 doses, 5 years apart in a lifetime. But there is a consideration on, or there's a way wherein you can have both PCV13 and the PPSV23. For example, if you have never had a pneumonia vaccine ever in your lifetime, or there is a significant number of years when you had your last Pneumovax 23, then you may consider this combination. You may start with the PCV13, then a year after you will have a PPSV23 shot. Okay, you may have that option. You may give that to your parents, especially if your parents have no history of pneumonia vaccinations. Okay, at this point in time, wherein there's a pandemic, it is very important to be vaccinated with flu and pneumonia. There was an article before, and it was published in a medical journal, wherein it says that the PPSV23 connotes a decreased severity in COVID-19 pneumonia. It is not used as prevention. Ha, dili siya for prevention. Basi ingon mo nga, ingon Dr. Valmoria nga, magpa-eject ko PPSB23, okay na ko, din ako magka-COVID. Dili. When you have your pneumonia or your PPSB23, you would have um, a high chance, or you have better chances at not having a severe type of COVID-19 pneumonia. Okay, so before I end, we have to remember guidelines are meant to guide and not as a rule. Therefore, these pneumonia guidelines are there to help us in the management of patients. But remember, we must always tailor our management to each of our patients. Dili pwede nga kay okay man siya ani, mo say buhaton na ko ani. Mo sila akong buhaton ani. So you always have to individualize your management with each patient you encounter. Okay? So that ends our lecture on community-acquired pneumonia, and I hope to see you in our Q&A session soon. So I hope that you'll be able to pull or to think about the questions that you have about pneumonia, and I will try my best to answer them accordingly. So see you, and thank you for listening, and have a good day.